Welcome back from break, everybody. Here we go. We're off to our next presenter. Our next presenter is Dr. Michael Mannstadt. He's the chief of the endocrine unit at Mass General, an associate professor in medicine at Harvard Medical School, both in Boston. So we all know and love Dr. Mannstadt.
Thank you very much. It feels like my fan club is here. That's great. So first of all, let me congratulate you on this amazing meeting, amazing discussions. It's always humbling how much you can learn about the disease you think you know. And it's also technically, it works fantastic. It's well done by everybody involved here. So you might wonder why an endocrinologist speaks about the kidneys, right? You have heard a lot already, and it's also on purpose. It's good to have facts shown to you from different angles. So you've heard already a lot about kidney health, but because it's so important for hypoparathyroidism, I want to give you my view on it. So the next slide will show you my disclosures. Doesn't want to. Oh, now it goes too fast. Wow. If I can get the second slide, that would be great. And yeah, and now the next, let me actually click on this. Yeah, okay, perfect. So you see the two kidneys, right and left kidney, that do all the work, that are exposed and clear the blood that comes through every minute in huge amounts. And then it filters everything out and is left with just a tiny amount that goes through the ureter down to the bladder. It's stored there and then discharged out. And that's what the kidney is doing. What is hypoparathyroidism a risk for? Well, there are at least three different things. One is kidney stones, one is nephrocalcinosis, and we talk more about it, and impaired kidney function. So we all love the parathyroids, right? But we have to acknowledge that the kidneys are a close second. It's a miracle organ. You see on the left side how it looks from an anatomical point of view. You see that the renal artery in red comes in, and then in blue the vein comes out, and in between is really a miracle what kidneys are doing. On the bottom you see some of the functions: removing waste products, regulating fluid balance. So whether you drink or you don't, the kidneys get the signal from the brain how the water balance is like, and decides whether to hold the water or not. It balances electrolytes like phosphate, magnesium, calcium, and is responsible for the acid-base balance. It produces hormones. It's an endocrine organ. Why the parathyroids produce, as we know, just PTH. Here it produces hormones that are important for the blood pressure control. It's the renin, angiotensin, aldosterone system that some of you might know. It is the site of the main production of 1,25-hydroxyvitamin D, what many of you take as calcitriol. It originally comes from the kidneys, and that's mainly responsible for the circulating active vitamin D. And it produces a hormone for the production of red blood cells. So highest respect to the kidneys. On the right side, you see how a nephron looks like. It's kind of a pipe-like structure, but it's really complicated. There are many different cells and cell types that are responsible for doing the work. And this is an example here. It's small, so you don't have to see and read all the little words here. But on the left side, you see the so-called proximal part of the kidneys, responsible for phosphate reabsorption under the control of PTH. So PTH tells the kidneys to lose phosphate, and if you don't have PTH, you cannot lose the phosphate, and you have high phosphate in the blood. And then more calcium is reabsorbed all the way along. On the right side is the main action of the fine-tuning of the calcium excretion, and that is under the control of PTH. So without PTH, it's not that you lose all the calcium. You lose the fine control at the end, right? Otherwise, you would end up with 10 grams or something of calcium. And what is hypercalciuria? Is too much calcium in the urine, and nobody can really feel how much calcium is in your urine or see. And so, but it's a risk factor for developing kidney stones. So the only way to really know how much calcium is in the urine is by collecting a 24-hour urine collection. And so many of you know, but are there any, actually let me first show hands who has collected a 24-hour urine. Excellent. Who has collected one this year? Oh, I like to see that. Who has not collected one in the last 2 or 3 years and has hypoparathyroidism? Yep, okay, thank you for being honest. It's one thing if you don't look at it, you won't see it, right? That's why my mother never goes to a doctor. It's good you listen to this talk. Now, you have heard a lot about these magic numbers, 250 milligrams per day as the maximum for women and 300 for men, and we use it, I use it, but just that you know, there's not a lot of science behind this. It's hard to say, oh, it's too much, you should reduce it without having a number. That's one of the reasons I use this number, but it's a gradual increase in risk, right? The more calcium in the urine, the more of a risk of a calcium kidney stone. It's not a magic number, oh, I'm 249, now I'm out of the woods. Do you know that not only calcium is measured, but also the creatinine? Are you aware of that? Yeah. Do you know why? It's written there. It's it's a control. The simple reason is it controls for the correctness, the completeness of the collection. Why? Because in every single person, the excretion of creatinine from day to day is the same. So whatever you drink and eat and whatever, right? And so in the ideal case, if you had 2 different collections of urine, right, one in June and one in December, the amount of creatinine should be plus minus roughly the same. But if one collection shows 500 milligrams and the other one 1,000, one of them is wrong, right? And either you're over-collected in one or you're under-collected in the other. And so if you remember that and have nothing else to do, you just look at your last 24-hour urine collections, look at the total amount of creatinine per day, and it should be roughly the same. And if there's an outlier, look then what the calcium is, right? If you under-collected and the calcium is low, you might be thinking, oh, my calcium is great in the urine, but it might not be. And interrupt me if you have questions, but otherwise we also have some minutes at the end. And so you're well familiar, though, on the left side is how PTH works to increase the serum calcium, among others to reclaim the calcium from the urine. But on the right side is what happens if there's no parathyroid hormone. Nobody tells the kidney to kind of keep the calcium inside in the last part of the nephron, and you have a loss of calcium in the urine, and the more calcium and calcitriol you take in an attempt to increase the serum calcium, the more appears in the urine. Right? So that's the whole problem, and that leads us to this central challenge in the management of hypoparathyroidism, and that is on the right side, if the calcium is normal for the population, it's actually too high for people not on PTH, because that leads to hypercalciuria and all kinds of things. If you lower the blood calcium, you lower the urinary calcium. But you can only do this to a certain degree because otherwise you have symptoms on the left side, right? Hypocalcemia. And so the only reason why we recommend the lower part of normal or just below normal is the urinary calcium. There's no other reason. Otherwise, why would you do that, right? And so, therefore, if you're running on the low side as instructed, but don't measure the 24-hour urine calcium, something is missing, right? You should actually really be aware of the urinary calcium. And so what are the consequences of hypercalciuria? On the left side, you see the stones, and you've seen them yesterday. The most common one is calcium-containing stone, and among them, calcium oxalate crystals. On the right side, you see our very simplified, oversimplified thinking about this. So the higher the concentration of electrolytes like calcium, the more likely they will crystallize, right? That is in this picture. And the more you drink, the more you go down to the dilute ones, right? And so if you dilute, then you don't form stones. That's kind of easy to understand. Reality in medicine is always much more complicated. And so kidney stones, how many of you have or had kidney stones? Wow, that's quite a bit. And how many of those had painful episodes of kidney stones? Ouch. Okay. Here we go. So you are the best witness to talk about this. It's very painful, and the smaller, actually, the more painful, I was told, and the bigger ones sometimes don't move. But remember that kidney stones is not something that is specific to hypoparathyroidism, right? In the population, up to 10% of men will have had a kidney stone by the age of 70. That's pretty substantial, right? Doesn't mean an episode of pain, but having kidney stones. So urologists are, of course, the people who are involved. And so having a kidney stone doesn't necessarily mean it's because of the hypoparathyroidism, but it's a risk factor. So most of them are calcium-containing stones. These stones should ideally be analyzed because there are specific treatment options for the prevention of another stone depending on what kind of stone you have. And that's how they look like. You see on the left side, that's a CAT scan. That's kind of a slice through your body. You see the biggest organ there on the left is the liver. And then you see the lower parts, the two kidneys. And on the image on the left side, the right kidney has, it's called the left kidney here, but has a big white stone, right? This big white structure is a stone. And you see a similar picture on the right, a CAT scan that goes a slice this way. You see this huge white stone, and you can imagine this is not good, even if it might not cause pain, because it interferes with this nice function of the kidneys that we have alluded to. An ultrasound, they look like a weather forecast, but this yellow arrow here shows you where the stone is, and it has, with the white arrow, this particular shadow afterwards that's typical actually for kidney stones. And what is nice about ultrasound, it does not use radiation at all, right? So that's a very nice test. CAT scan is another test that's very specific and sensitive. So these were kidney stones. Now the other problem is nephrocalcinosis, and they are somewhat related. Nephrocalcinosis is really the presence of calcium salts within the tissue of the kidney. So not just in a tubule hanging somewhere, but within the tissues. And if you see the CAT scan on the left lower side, you see these little white dots right and left where the kidneys are. These are calcifications, so calcifications of the actual kidney tissue. And on the right upper one, the one with the right and the two black spots, these black spots are calcium crystals. This is what nephrocalcinosis is, and it doesn't go with pain, but you can see it on imaging, and this can reduce the kidney function. All right, and so speaking of kidney function, that's the third one. The hypercalciuria can lead to impairment of kidney function. CKD, we say, chronic kidney disease. And so there are blood tests that you know, creatinine and BUN, that tells you something about it. And then there is a calculated result that's called GFR, or estimated eGFR. That's the glomerular filtration rate. The better the GFR, the better the kidney function. And so we have different stages. And people, yesterday somebody said, I have stage 3. So what is stage 3? That is if the filtration is between 30 and 59 milliliters per minute. The differences between like 90 and 80 is extremely small. It's within kind of the almost normal range, right? But then when you get down to less than 60, then differences do matter actually, or can matter a lot. And therefore there's also a 3A and 3B, with 45 being the threshold between the two. And then very severe and end-stage renal disease, that means dialysis, actually, right? So the higher the GFR, the better, actually, in general. And so remember, though, that there are risk factors for CKD that are more widespread than hypoparathyroidism. And so diabetes and high blood pressure are the most common ones, and you want to be very concerned about these and having good control for your kidney function. How many of you have high blood pressure or are treated for high blood pressure? See? So that's kind of where you really have to watch out. You want to be very cognizant about your blood pressure. You measure it at home. You have a little list or an electronic ways. You go to your doctor, you show that, not just one measurement in the office. And you put a lot of energy into the control of the high blood pressure. This is what is really important for your kidney function. Hypercalciuria, high calcium in the urine, is also, but really these are very important. Remember that the GFR, as we get older, and my definition of old changes every year, as we get older, the GFR naturally declines, right? And so if you have a GFR of 68 and you're not the youngest, it might be just because of age. Nephrocalcinosis, as we said, is probably a risk factor. It's actually hard to study this whole connection in hypoparathyroidism because there aren't a lot of big studies that really show us. So we deduce a lot from our knowledge from non-hypopara patients. And then one question is, does it progress, or how fast, how slow, right? So let's say it is slightly impaired but stays pretty stable over many years. Well, that's obviously a good thing. And so we did, many years ago, a study in 120 patients in the Boston area with chronic hypoparathyroidism, and we asked several simple questions. One was, how many had a 24-hour urine that we could find in the electronic medical record? And guess what? Only half of them had one. Right? It's a problem. Of those who had one, you see on the right side in this dot graph the 24-hour urine calcium, and the gray is more than 300. There were quite a few who had more than 300 milligrams per day, and that's high. Now, what about imaging? And so some had imaging for whatever reason, and when we looked at them with the radiologist, we found that about a third of those who had imaging had actually kidney stones or nephrocalcinosis. And you see a more extreme example here on the left side with kidney stones on both sides. Now, what about the kidney function? Here we remember the lower the GFR, the worse, and so here we define it as less than 60. And on the right side, you see in black a very important graph, and these are US databases from people of all walks of life. You see that the CKD prevalence is higher the older we get. Right? If you follow the black bar, you have 20 to 39-year-old, 40 to 59, etc., and older than 69. The percentage of people with CKD increases. Now look at the gray bars. These are our patients according to age with hypoparathyroidism. So you clearly see it's higher than in the normal population. So we really have a problem, right? It's not just theoretical. And this is from a review that actually took studies that were published about the prevalence of CKD in hypopara patients. You see, several studies listed here with the date, the year that were published, and particularly of interest, the number of patients. You see there's some smaller studies, 33, and some very large studies, 688. And you see the percent of patients with CKD. It doesn't tell you really what the age was, right? And so the older the population, the more likely. But it gives you a range, and it just happens that our study had actually the highest percent of patients with CKD. Now, let's look in more detail about to the last study with 688 patients. This was a nationwide Danish study where in Denmark everybody is captured electronically. And they took post-surgical patients, 688, and chose age and sex matched controls, and found the risk of kidney disease in patients with post-surgical hypoparathyroidism was about 4-fold higher. That's a pretty stark number. But you also need to know 4-fold of what, right? If there is a very low risk and you have a 4-fold risk, it might still be low. And so that's not often talked about, but I put the number from this article here for you. So you see the risk of kidney stones in the controls, 2,000 controls, was 0.4%. In hypoparathyroidism, it was 1.9%. And you decide for yourself, is 1.9% very high or very low? It's obviously higher than non-hypopara patients, right? But it's not like everybody gets kidney stones. And CKD, chronic kidney disease, the function of the kidney, similarly 1% in controls and 5-fold higher, 5.1% in hypopara patients. So you get a little bit of an insight into the numbers, right? It's relative risk, meaning how many fold higher is one part, but then what's the absolute risk, like in percent, which you see here. So I just threw this in. Just let's talk about a practical case. So we have somebody who is otherwise healthy but has post-surgical hypoparathyroidism and comes to the office with the following medications: Citrical, 6 tablets twice a day, calcitriol, 1 capsule, levothyroxine daily. And here you see the serum calcium measured over several months, ranges from 8.5 to 9.9. Serum phosphate is slightly elevated, and the 24-hour urine is there. Normal vitamin D, magnesium, TSH, occasional tingling. What do you like and what you don't like, and what would you do here? Oh, I like that. So lowering the calcium tablets and increase the calcitriol. It's an excellent point. Why? Well, it has many different reasons. One is 12 tablets of calcium. That's quite a bit, right? Who takes more than 12 tablets of calcium per day here? Ooh, I'm glad to see that. Nobody. Excellent. It's impossible, to be quite honest. Why not increasing calcitriol, right? That you get much more bang for the buck. It's very potent. It's in micrograms. There are 0.25 and 0.5 microgram strength. So if you're on a higher dose, you can switch to the 0.5 if you and your doctor agree. Excellent. Then twice a day calcium, right? Is that enough? No. Instead of having these 2 peaks of serum calcium a day, because calcium is relatively short-acting, you want to have 3 times a day or sometimes 4 times a day. If you take it with meals, which we recommend, you also bind the phosphate. It's one of the ways of lowering phosphate, right? So there are lots of little things. So what did we do? A little hard to read here probably, but we switched this patient actually from calcium citrate to calcium carbonate. We can talk about this in more detail. You don't have to do this, but for this patient it was fine. What you get is you get more calcium per tablet. So if you don't need citrate and you don't have other reasons, then calcium carbonate actually is a fine choice. 3 times a day with meals. So we lower the total amount of calcium from 3.7 grams a day to 1.5 grams, which looks much more reasonable. And we increase the calcitriol and give only 1.5, and indeed the serum calcium overall went probably down a little bit, but didn't have these swings. Serum phosphate, more or less the same, maybe a little less, but the 24-hour urine really went down, right? From the 350 to 450 to 290, and rarely symptoms. So that's actually a good thing. And there are many other ways. Now, what do you do with the 24-hour urine if you want to be lower than that, right? It's getting a little difficult, but what can you do? One is exactly what was said, that the decreased filtered load of calcium can decrease the urinary calcium. So you want to lower the serum calcium if possible. Now, if you're running at 8.0 already, well, you don't have much room, right? But if you're 8.7, maybe you can go to 8.3, right, on average. And so only you and your doctor can decide what number is too low and what not, and that differs between people, right? And when I say numbers, it's just a number that I often see. It doesn't mean it applies to every one of you. The distribution of calcium supplements evenly throughout the day is really important. Thiazide, you've heard about this. This is a medication that can lower the urinary calcium if you have a low salt diet. Otherwise, it doesn't work. And of course, PTH or PTH analogs. Right? That's the obvious drug that is missing and can actually lower the urinary calcium. Reducing pill burdens. So I really, in the past, we treated too many people with too much calcium, actually, and so now calcitriol is really a help here. Calcium carbonate is okay for many patients. And so kidney health, what can you do? So one is keeping the serum calcium as low as you can, and divide the calcium throughout the day. And then also one question that came up yesterday, I think, was the timing of the calcium check, right? So in the morning, before you take your morning medication, it's the lowest calcium of the day for most people. Are you interested in that? Sure, if you want to avoid symptoms, but you also feel the symptoms in the morning, right? But what about in the middle of the day? Well, some of you might see your doctor in the middle of the day and have labs done then, right? And so they might be slightly different. So I personally, if you can, encourage you to have both. Several calcium values that are presumably the lowest in the morning, and then several throughout the day. See how the calcium is. And if you see, well, actually, it is pretty high during the day, I don't have symptoms in the morning, you might be able to lower it. Or you might be able to switch the last calcium of the day later at night. All these little things matter because it's not a disease that you take tablets for a week or 10 days, like an antibiotic, and then you're done. Here, you really want to fine-tune. And so the 24-hour urine calcium measurement, we talked about calcium and creatinine, but there's also another measure that you can take, and that is, was mentioned yesterday, litholink. So stones form because of an imbalance of inhibitors and promoters of crystallization. Calcium is just one of them, so the picture is more complicated. There are also inhibitors that you want to have of the crystallization. And they can be measured by a so-called stone profile of the urine. And so this is what it can look like. And you might not see all the numbers, but it kind of lists on the left side several electrolytes like calcium, oxalate, citrate, etc. And then it gives you the numbers, and it kind of displays them. Green is good, yellow is okay, red is too much, right? And so it's visually very easy to actually see. And then you can see, oh, my volume is 1.5 liters. This test tells me I should actually have a higher volume, meaning I should drink more, right? Or oxalate is too high. Oxalate is bad for kidney stones, and it's in everything that's good, like chocolate and nuts, etc. So you might have to think about what you eat. And then it gives you also a table, and it lists everything, it lists the normal range and stuff. So for those of you who had kidney stones and who haven't done that, talk to your doctor about this, right? It can be actually very useful. Also talk to a nutritionist if necessary. Fluid intake, very important. Diet, sodium and proteins, so meat, can actually increase the risk of kidney stones. Thiazides, we talked about, lowering oxalate, and if the citrate is low, your physician will talk to you what to do, but one thing is potassium alkali. And don't forget, for kidney health, blood pressure, diabetes, and weight. All right, so that was what I wanted to talk about. Thank you very much for your attention, and I'm happy to take any questions.
Thank you.
Hi. So those of us that have stones, if we get any that are bigger than 5, luckily I haven't yet, what is your position on lithotripsy? My care team is split. One has said, don't ever let them use that on you because it's more damaging to the kidneys, and the other has said it's fine. What's your thought?
Yeah, excellent question. I have to tell you that I'm not the right person to answer that.
Okay.
What I would say is depends on the size and location. And the best person to talk to is the urologist. Now, it's like going to the hairdresser and you get a haircut, right? And so you go to the urologist, they might actually favor a lithotripsy, but they are the ones who have the best experience and will tell you.
Hi. Okay, my urine calcium was 720,
Wow.
but I'm only taking 900 milligram of calcium. What are your thoughts on that?
And do you take calcitriol?
Yes. 2.25. No, 0.25 2 times a day.
Got it, so 0.5 a day, right?
Yes.
Yeah, and what is your blood calcium?
It was 9.3.
Yeah, so the calcium excretion has a huge variability already in people without parathyroid disorders, right? They can usually be in the 100, 200 range, but there are people running around with way higher levels, and they have nothing wrong with their parathyroids as far as we can tell, right? And so Dr. Roberts had talked about this, the idiopathic calciuria. So you might have had that before you acquired hypoparathyroidism. But I would argue, first of all, you are not different than the mean level of calcium and calcitriol that you need for hypoparathyroidism, even if people attending this conference might actually on average have a higher requirement, right? But if you look at large studies, 0.5 and about a gram is kind of the mean. But it might be too much for you. So serum calcium of 9.3, which is smack in the middle of the normal population range, is exactly what I was talking about, this balance between a normal calcium, which is too high for hypoparathyroidism, and the hypercalciuria. So you might want to, if you haven't done already, try or consider decreasing calcitriol. And see what does your blood calcium do and what are your symptoms. And if both are okay, then check your 24-hour urine and see how this develops.
So it's better to lower the calcitriol right now, not the calcium.
Yes, so that's a detailed question, depends on many factors that we might not be able to discuss now. In general, if the calcium intake is roughly what a person with normal parathyroid should take, like 1,000 milligrams a day, if that's your intake, I would not really change that too much, but then switch the calcitriol. There's an exception, and that is if your serum phosphate is high. It is high? Well, exactly. So then
It's 4.9.
keep the calcium, right? Because that binds the phosphate and lower the calcitriol. So it's relatively straightforward in your case. Here we want to decrease, so we decrease the calcitriol and keep the calcium tablets. Sorry if that was confusing.
So I became hypopara in 2007. I finally convinced my endo to do a 24-hour calcium in 2019. That
Good for
was
you.
my first one.
Good.
At that point in time, my creatinine was 1186 and urine calcium was 289. The next one that I finally convinced them to do, actually because of having some issues, was in November 2020. And my urine creatinine was 2390, and my calcium was 605. And they didn't say there was anything I needed to do. We did trial HCTZ. Unfortunately, I had some other complications, so I couldn't take it. I'm on aldactone, which supposedly, I guess, does something similar, and I'm doing okay with that. Should I be trying to get them to do another one now?
Yeah, no, it's nice that you have the numbers. You realize that your two different collections had 200% of the first one was your creatinine, right? So that doesn't add up. And it's exactly what I was mentioning. You had 289 and then you had 600, right? So let's say your first one was the correct one and you over-collected for the second one. Then if you cut it by half to get about 1.1 gram of creatinine, your urinary calcium now is 300 and something, right? It's still a little high, but it's very different from the 600. And that's precisely why I mentioned the creatinine. So it's good that you have the numbers. Now, how do you decide which one is the correct one? It's a little tricky, but women, so it's a muscle mass question, right? And so if you have a young bodybuilder, 2 grams is kind of what they have. If you're a woman and not a bodybuilder, you might have 1 gram or even less. If you're a very tiny, fragile 70-year-old woman, you might have half a gram, right? And so it looks to me that there's a possibility that the second one was an over-collection. How do you over-collect urine, right? I mean, you want to get done with that. One reason is that the first morning where you should discard the urine and then start, you might not have discarded it, right? You might have collected that and the next morning one. Or if your volume was very high and you needed 2 bottles, what does the lab has to do? They have to mix them and then take a sample and measure it. Because one might be when you really drank a lot and it's very dilute, or at night you didn't drink at all, it's very concentrated. And if they only measure one, well, it's useless, right? And guess what? It happens again and again. It happened this week, actually, to one of my dear patients who already got crazy because I wanted so many urine calcium. And he collected, he had a huge volume, which I always like. And I told him, well, tell the lab to mix them. He did, and they said, who's the doctor, you or me? And they didn't. And then the mother he's a young guy, mother actually was very inventive. She they collected the urine, 2 bottles, put them in and put a tape around it as a, per my doctor, please mix before you measure. And they did. And it was half the value that was there before, right? So these are the little things that matter.
Okay, we have some online questions.
Okay, I'm going to start with, can the body dissolve or reabsorb kidney stones once your calcium levels are properly maintained?
Excellent question. Now, previously I would have said no way. But in children, nephrocalcinosis or calcifications can come and go. In adults, I'm less sure. So I would presume they more or less stay.
Okay. Is chronic kidney disease reversible, and if so, up to what stage?
Excellent question. So that depends on many factors, among others, why the kidney function was impaired. Typically, it's not really reversible unless it's something acute, and the acute setting, it can be reversible. Children, everything is possible. And there is also a day-to-day fluctuation of GFR, and it depends, among others, on your hydration status, right? So you might have stage 3 with 55, and then the next day you have 61, and you say, whoa, look, I overcame this, right? And these are relatively small changes. So it depends on many factors.
Okay. Is it important for us to include a urologist on our treatment team? When should we see them? And is there a criteria, or should we see a nephrologist instead?
Excellent question. That all depends a little bit on you and your primary care physician and what the degree of your disease is. So in general, for kidney function reduction, so for instance, CKD stage 3, etc., you want to see a nephrologist. And so you should talk to your PCP and saying, well, I see that my GFR is X, Y, and Z. What do you think about seeing a nephrologist? And what does the nephrologist do? They don't do magic, but they will be very good in identifying risk factors and what you can do about it, right? Blood pressure being one of them. If you have a kidney stone, then you might want to have a urologist on board. So the question, which one can be destroyed or should be or not, right? That's a urologist who can tell you.
Then they fight sometimes.
And you see, yes, yes.
That never happens, right, Dr. Mannstadt? All right, so thank you so much for your time, and I know you got some